Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Okay, thank you so much for setting aside a little time today to spend some time with us. Appreciate you being here. If you've not been here before, or if you've been here before, welcome back. If you've not been here, Dr. Randall Juliff is the medical director of Vein Clinics of Hawaii on 4 islands: Big Island, Kauai, Maui, and here on Oahu, where we do this show. And I didn't tell Doc this, but we've reached a rather significant milestone.
Oh, what's that?
This is show number 100.
Oh, nice. Very nice.
Yikes.
We're closing in on 2 years then.
Yeah, and I can almost do the procedures by myself, but not really. But one of the things that we do, as you know, is most of the time the show is pretty structured and we have a goal in mind and we explain and have interaction with Doc on all kinds of things to do with your circulation and what he does, venous surgery. And every now and again we can go freestyle a little bit, and instead of really having a specific agenda to talk about a specific part of venous disease or insufficiency, we get to actually spend some time with the patient, and the proof's in the pudding. And you're going to learn from a patient today. His name is Paul, and we'll be joining Paul in just a minute. But Doc, this is sort of where all of these stereotypical ideas people have about your business really learn something. And so today we're going to talk about somebody who is much like me, some of the conditions that I've had as a patient, but once again a male. And when in the past, that's all women. Men don't do this. Only the women do.
Yeah, and that's why I love to have patients come in, because you're right. We're kind of busting myths about vein care and vein disease. And when real patients come in and talk about their specific experience, it hits home so much more with people, I think, who are out there listening, as opposed to us talking about potential symptoms findings and all that sort of thing.
Absolutely, it does.
So it's a good thing.
And and there's another thing too, and that is those of you that if you've been around for a few shows, you know that. I had to thank my mom very much for venous disease because she gave it to me. It's hereditary. And my mom went through stuff in her day. And when I finally found out that I was going to have to do stuff, I was just scared because, she went through some miserable times, as did our patients today. And it's kind of neat because in many respects, sometimes, Doc, you talk about the old procedures are gone, but in some cases they're not. In other words, before we get into meeting Paul, let's talk a little bit about vein stripping, which was the old show. Remember, you open up the legs and you strip the veins out. And it was pretty invasive.
Yeah, well, very invasive.
Yeah. But it's still used a little bit sometimes.
Unfortunately, it is. Yeah. Every now and then we have a patient come in and they talk about the fact that they had, old-fashioned surgical vein stripping at some point in the not-too-distant past. And it's unfortunate, but, we better late than never, they get to, the point where they're open to modern vein care. But yeah, in the old days, and I remember doing some of that stuff when I was a surgical resident many years ago. But people were in the hospital. Not only did they have, big incisions and a long recovery, et cetera, but they also had, significantly they required a general anesthetic. Which bringing vein care into an office setting, one of the real benefits of the process the way we do it now is eliminating general anesthesia, because general anesthesia in and of itself is a fairly significant risk of undergoing any surgical procedure for that matter.
Now, walk in, walk out. That's what I've done.
Yeah, and so we don't do that at all. We use a process that we call tumescent anesthesia, which is kind of an extensive, local, numbing process. So it's so much easier. The procedure that has taken the place of vein stripping is something that we call endovenous ablation. We don't make any incisions. Everything's just done with little needle puncture sites. And that procedure that used to take several hours in the operating room and a hospital stay
and sick leave, a lot of stuff,
and off of work, right, which is an important thing. Lost wages, etc. It takes 30, 45 minutes in the office, and the patient leaves the office and goes on with their day.
Okay, now this is maybe it's vying for, not only is it show 100, but it's also vying for one of the longest introductions that we've done since we started this. Right? And that is, and I know Paul, and actually Paul, our patient, became a patient of Vein Clinics because of his relationship with me and with the radio station.
Right.
And so the proof's in the pudding. And I just learned before, when we were getting ready, Paul, that you'd had some of the old-fashioned stuff. First of all, thank you very much for joining us. Appreciate you being able to share your story with us. But one of the things that's kind of neat is you went through the old-fashioned stuff. I want to be a fly on the wall here. I want you to talk to Paul about what brought Paul not just to your door, but to get the treatment that obviously he needed, and he's had some interesting new procedures done.
Yeah. Well, I think what the first thing about Paul is that you had fairly early onset of symptoms and things that you saw on your leg that were concerning to you that you didn't see other people have at a fairly young age, right?
That's correct.
How old were you?
About how old?
I was 25, I think, when I first started my first symptoms.
Wow.
And my legs were bulging out. And I went to the doctor here back in 2004, and I was like, Doc, this can't be normal. I mean, this is, I'm a young kid. I'm still exercising. I'm still surfing and stuff like that. But I'm noticing the veins in my leg just sticking out.
Did you see anything during your high school years?
No.
It was just
my
mid-20s that you started to see stuff, which is still a very early age, So typically when we see, youngish males with early onset disease, we ask them about their family history, because it's so common that, if you have such an early onset of what would be otherwise what we would call primary venous insufficiency or kind of garden variety venous insufficiency, usually those people have a pretty strong family history, and I believe you did.
Yeah, my mother.
Yeah,
she has the veins.
And did she ever have anything done with her veins?
I believe she did. And the old stripping method. So
yeah, same sort of thing.
Which is
you
very
had
painful. I
initially.
remember I went to Queens Hospital.
I don't like pain.
No.
And here you go.
It was horrible. Yeah, in 2005, I went to Queens Hospital. They put me under with anesthesia. And I woke up, I think, 4 to 5 hours later. My leg was wrapped up. I couldn't walk for several weeks. I was out of work. And which is why I waited 15 years to get it done the second time, because I was like, I don't want to go through this thing ever again.
I want to tell you exactly the same thing. Exactly the same thing. Doc knows, and a lot of our audience knows. My mom, self-made business lady, retail, standing on her feet for 40 years, varicose veins, big time. I mean, major stuff. When Mom had a procedure done, and she had several, she was literally out of it for a week or two at a time.
Yeah.
And now and I've had similar procedures that my mom had, and I was walked in and walked out.
Right.
What a deal.
Very painful. Very painful.
Which is one of the reasons why I was attracted to vein care. My prior life was more in the hospital and in the operating room and doing, surgical procedures
with hearts,
there.
Working on people's hearts.
Right? There's just been so many new, devices and techniques that have been developed over the last, 15 to 20 years that have allowed for that, that have allowed for the kind of walk in, walk out kind of method. and it's been great. You know, I mean, people love it, and they really, you know, are their symptoms are addressed, and by and large, you know, everybody does very, very well.
You know, Paul, but you know what I think is kind of neat in the you said bulging. So was it the appearance, or was it symptoms, or both?
They were bulging. They hurt. I was tired all the time. I was, you know, restless leg. You name it.
But okay, so in other words, it wasn't just appearance; it was hurt.
Oh yeah, of course.
So, but did you notice them a long time before you got treatment?
Well, like I said, I did my left leg in 2005, which was very painful, and I was out of work, I think, for 3 weeks. I couldn't walk for 2 weeks, which is why I waited 15 years. And when I met you and Dr. Juliff, they were talking about non-invasive surgery, poking your leg in and out of the office. I'm like, okay, sure. I've been down this road before. Yeah. So I mean, I walked into his office and I was like, I was completely amazed. Yeah. You know, 45 minutes, one treatment. They did a treatment for I think for 5 days. And my leg hasn't looked better. In fact, I even wore shorts today to show the audience.
But here's the thing that I find incredible. It's when the symptoms go away, it's one thing. Appearance is one thing, and I guess us guys are a lot less likely to have surgery just because of appearance. You know, but the going away of the symptoms or the pain. Where in previous program, if you were with us last week or the week before, you learned that what we're doing is we're talking about putting somebody in the pecking order of what stage of the disease was he in. So where was, when you met Paul, who had already had these procedures done in early 2000s, what stage, where was he?
Oh, the skeptic stage.
He would have been probably C3,
okay.
You know, the of the SEEP classification. So his clinical level would have been 3. So what do we mean by that? Well, C1 are people who just have spider veins. You know, that's all. That's all you see on exteriorly on their leg. Now, they may or may not have significant underlying venous insufficiency. Some of them don't. Many of them do. But that's what we call C1. C2 are people who have, you know, obvious varicose veins. So, you know, dilated veins on the surface of your leg. They're not the tiny little ones that are in the skin. They are, by and large, varicose veins almost always indicate that there is underlying venous insufficiency because that's how they develop. You know, venous insufficiency means that the blood in the deeper veins in the legs is going in the wrong direction, and the pressure within the venous system elevates, and that's what then leads to, you know, dilatation and you know, the throbby discomfort in the area of the varicose veins. So you had plenty of varicose veins. And then I believe you had a little bit of swelling.
Oh, yeah, a lot of swelling.
And so that then gets
both legs, or one worse than the other.
Well, I mean, they started to come back in my left leg but my right leg, it was just very, very painful. It very, very swelling. The heat, you could feel the heat off of it.
Yeah.
I was always tired. My leg always hurt. I always had to put my right leg up.
Yeah. So that would the swelling then kicks you up into the next, you know,
Gotcha.
status. So Paul would have been a C3. Now, luckily, he did not have any significant, you know, what we call skin changes. As I recall, you didn't have any pigment darkening of the skin and the ankle. Yeah,
not like me. He's better off than me.
Right. Yeah.
Thanks, Mom.
So you know, so in that has its that has its own, you know, set of implications when we start to see those skin changes, because that's a higher clinical level, and you know, it indicates a little, you know, worse state of venous function, probably a little longer lasting, or long, you know, it's been going on for a longer period of time, and so we don't, you know, one of the reasons why we treat people in stages, you know, 2 and 3 is so that they don't get to C4 or C5, 6, because we don't want that skin to be permanently disrupted, and because that's what leads ultimately to you know, venous ulceration. That's what we don't want. But yeah, Paul would have been C3, and he had what we would call primary venous insufficiency.
And because I'm always interested when you had the first procedures, you were out of work for a long time. How long have you been seeing Dr. Juleff? About? We're looking about like within the year.
Oh yeah.
I think, yes, that's correct.
I think you first came into the office maybe four or 5 months ago.
February.
I think
February.
Yeah,
January, February.
Yeah. So, but Paul had been wearing stockings and doing the most
right things.
The most of the conservative measures, because as you know, Medicare and insurance companies, they want us to treat people for some short period of time conservatively. Yeah. To make sure or to prove that conservative therapy isn't going to be enough for that individual patient, which very, very rarely it is, because part of that problem is that nobody wants to wear stockings every day of their life.
Hey Paul, wait, I got to ask Paul about that because we've never talked about this. I was kicking and screaming and just not wanting to do that, and now that I do it, I even do it every day.
There's multicolor stockings now. They have pink, they have green, they have blue.
Yeah, but see, I don't have those. I have the.
Why not, Mike?
Do you want the brown one? I mean, the tan ones or the black ones? That's it. But I do know, and we talk about this on a regular basis, that once you do it, I mean, it's a pain and all that stuff. Yeah. But once you do it, it really does make a difference. Then.
I mean, I was because of my surgery in 2005, I was kind of, cautious about having surgery again, so I was trying to do everything to avoid that.
Of course.
But I needed to go to the vein doctor to go see Dr. Juleff because it was just time. 15 years later, and my legs were still swollen, still in pain. And I'm still wearing the stockings.
Yeah. Now, do you wear the knee highs or which socks do you wear?
The thigh highs.
Yeah, compression garment, thigh highs.
Yeah.
Which
the thigh high compression stocking is the one that we want people to wear over the course of the procedures that they're having done, as you know. But the compression stockings really are beneficial for just about everybody, quite frankly. Yeah. So I recommend to almost all of our patients that even after we fix their venous problems, it's still a good idea to wear. You don't have to wear a thigh high stocking, but a knee high compression stocking. If you get used to using them, especially if you're on your feet a lot, usually what I tell people is, hey, if you have a job that you're on your feet a lot, then it really will be beneficial for you over a long period of time if you just get in the habit of wearing a knee-high stocking at work, just at work alone.
Yeah, and I have a tough time in explaining to people that they're not socks. They are a garment. They're not just a pair of socks that you buy 6 pairs for $3 and off you go. They're expensive. You got to take care of them. But boy, they sure make a difference for me anyway. Every day.
Yeah. Well, their construction is very, very specific. We call them graduated compression stockings because they are. There's more compression lower in the leg, and then it lessens as it comes up, and it sort of, creates a mechanical situation where it's, pushing excess fluid and assisting the veins in moving, blood in an upward fashion.
Okay, I want to get to the juicy part. Let's talk about the procedures.
Okay.
Talk about we heard a little bit about the symptoms, how you decided what exactly was going on with Paul and what did he need.
Okay, well, so Paul came in for a consultation. We asked him a lot of questions, and he played with our iPad for a while. And
that's a job, man. It was good, but it was pretty good.
Yeah. And then
it's paperless.
Invariably, we the next step is usually an ultrasound to figure out what's going on. So he would have come back for an ultrasound. What do you remember about the ultrasound? Was it fun?
It was fun. Was that Steve?
I loved it because you could see it.
Mike,
Mike, great guy.
Great guy. Yeah, I mean you're right there. It's right on screen. They take the little gel, they rub it up your legs. They can actually see the vein, the venous insufficiency on the vein in real time, which is
Yeah,
amazing.
I mean, I was blown away. And
it's deep in your leg too. It's not like it's around the surface.
Yeah,
Sometimes these are.
the thing that I notice is I love the sound effects and it's gurgling and splashing. It made me realize, and I'm sure you too, Paul, that boy, there's a lot going on in there.
Exactly.
You know, and I was worried too. And I asked Doc about this. You know, we keep taking these veins out. You know, am I going to need some more? I mean, what goes on with this stuff? And it makes, once you get it, you know, then it's fine.
Yeah,
That's right.
Well, and that's it. I mean, it really, we like to have our patients kind of come to some understanding as to, you know, what the problem is. And you know, of course, we describe the procedures, and it's fun when they understand, you know, what the procedures are doing for them, et cetera. And it starts, I think, probably at the time that they come in for the ultrasound, because, you know, like you said, Paul, you're laying there, and Mike is our ultrasound tech.
Yeah.
He's very good. He's very accomplished at doing, you know, the ultrasounds, and you know, I got to tell you, not every ultrasound tech can do, you know, this kind of work, but he also does a very good job at showing you as a patient.
That's what I love.
What's going on?
Learning stuff.
And
Yeah, this part here, right there.
yeah. And you know, and again, Paul had what we call primary venous insufficiency. Well, what that means is that you know, there's tiny little valves in the veins, and you know, those valves can fail, and they can fail at any point in your life, but usually it's due to, you know, a genetic influence, and you probably had a very strong, you know, genetic influence because of the fact that, you know, your veins were failing at a very young age. But so anyway, the valves fail. And when we look at that with the ultrasound, we can see that. We can see the valves, you know, not functioning the way they should. We can see blood going in the wrong direction, which is what we look for. And then we can also, you know, look at all the veins in your legs, and we, you know, define which ones are working, which ones are not. Typically, it's not like all your veins fail. There's just, you know, several typical ones that we see, you know, most often, and then we're able to address, you know, what the problem is. So the ultrasound not only makes the diagnosis, but then acts as our roadmap when we go about detailing what we think needs to be done to fix the problem.
Okay, so Paul, you've had how many procedures with Dr. Jill now? Ballpark.
Several per leg.
There's maybe 8 or 9.
Okay,
procedures.
so and obviously
But it's painless and it's real short.
Yeah, that's what I like.
I mean, it's amazing.
Yeah, but what I also liked is they, after a while, they look really bad. You think, like, wait a minute, this looks worse than it did when I had them. But did you notice, like, the difference in healing from the first time around when you had the?
Well, of course.
Yeah, that's the part that
I could walk out of the office. I wasn't in a wheelchair or crutches. I had to get someone to drive me home. I mean, it was. He wrapped my leg up with some gauze and put the compression stocking on, and
out you went.
Out you went.
Right. Typically we do whatever it is that we're going to do, and sometimes, you know, if we're doing, for instance, an endovenous ablation, you know, we have to access that vein. We have to get something into the vein because we're going to use a catheter that we thread into the vein. So. But we access that catheter just in one little site, you know, then you know, at the end of the procedure, we, you know, put a dressing on that site, and the patient, you know, goes on their way. And there can be a tiny bit of discomfort, but not a lot. And you know, it certainly doesn't restrict, you know, most people from, you know, what they want to do or need to do. You know, so they have a little dressing on their leg, and we put their compression stocking on over that, and they, you know, they go on with their day.
Okay, what's at what point is he now? I mean, you know, he's had these procedures, obviously successful.
Yeah.
And we're working on what?
Yeah. Well, right now we so getting back to what Paul had, as I recall, we did endovenous ablation. Excuse me, of the two main superficial veins in both legs, That's the great.
I was going to say, we're talking SAF here, right?
Yeah.
That's what I know. SAF in the face.
Saphenous system. That's the superficial venous system, and which is good because that's the system where veins usually fail in most people. Fortunately, that's the system that we can easily do things with to intervene and make things better. It's a little more difficult to treat deep venous reflux, and luckily most of the time we don't have to. So he had 2 or 3 veins in each leg that we needed to perform this endovenous ablation on. And we do that by, again, getting into the vein, threading some sort of device. And there's a couple of different devices that we commonly use. One is called a radio frequency ablation catheter. Now, what that means is that radio frequency is just an energy source. It's like electricity or laser or whatever. It's creating energy, and what that specific catheter does is that it heats up the inside of the vein. So at the tip of that catheter is a little metallic segment, and that radio frequency generator heats up that tip. And so we're cauterizing the vein from the inside. Right. So,
in other words, you're burning it.
Yeah, we're burning it.
Yikes! You ain't burning my leg.
We're gently burning it. But in a sense, that is true. We heat that catheter heats up to 120 degrees centigrade. Well, in centigrade, 100 is boiling. Mm-hmm. So in centigrade, this is 20 degrees higher than boiling. Yeah. It gets hot, but we protect. We use this local anesthetic technique. It's called tumescent anesthesia to not only make sure that the patient doesn't feel that, because they would, they would definitely feel it, and also to protect the surrounding structures. From that heat, because that heat could very well burn, surrounding structures like, other blood vessels and skin if the vein is too close to the skin. So we inject a lot of numbing fluid around the vein, and it protects people from all that. But and I'm sure that while we were doing those procedures, you didn't feel any
nothing
substantial,
painless,
and
professional.
Here's the thing that I want. I mean, recalling what you went through, and it took you a long time to go through it again. Were you like me, laying there waiting for it to hurt? And then
yes, I was like, is that it? He done?
I love it.
That's it.
I like
there's
that.
There's some beeps, some squeezing going on, some needles, and you're done. You're like, what?
It's almost like and we sort of liken some other fields and specialties is like the dental equipment of today. You used to be able to see the drill going around back in the day, and now it's you're done. But I still think though that it gets you where you want to say, hey, whatever it took to get me here, this is where I want to stay. So obviously, I'm hoping that what we could determine is the severity of what Paul had was severe. He had some really serious stuff. And then what sort of monitoring thing do you think would be advantage to set up for him to maintain, to keep an eye on things?
Well, I just wanted to touch on one more thing, and that is, the procedures that Paul had before we get into the surveillance thing. So we use the radio frequency catheter pretty extensively on most of the veins. The other device that we use, which is an interesting device, and I thought I'd bring it up, is something called it's referred to as a MOCA, M-O-C-A, which it's not something to drink or eat.
What? It's not the latest from Starbucks.
We don't put whipped cream on it. But the MOCA stands for mechanical occlusion chemical assisted. So it's a device that we put into the vein, and out of the tip of that, it's a catheter, and
very little,
very tiny. And out of the tip of the catheter is a little wire, and that wire is sort of hockey stick shaped. And that goes out into the vein, and then we attach that catheter to a device that causes that wire to rotate, and it rotates very quickly, 3,500 RPM. And basically what that is doing is that it's abrading or damaging the inner lining of the vein. And we're not it's not perforating the vein. It's just irritating and making a superficial injury to the inside of the vein. At the same time, so we put that catheter in, we start the wire up, and we slowly pull it back. So while we're pulling it back, we're injecting small amounts of a medication that we refer to as a sclerosant, and there's a couple different ones out there. But so between those two things, the mechanical abrasion and the chemical medication that causes a inflammatory response, between the two of those, it causes the vein to collapse, and basically the walls just stick to each other, and the vein closes down. So that's a little newer device. It's been around a number of years. It's tried and true at this point, but that's another device that we use pretty extensively. And the reason that we use that is to avoid nerve injury to one particular vein in an area where that vein runs very, very close to a sensory nerve. And if we use that, the radio frequency, heat tip catheter, it can actually injure that nerve. So this is an alternate device which has been very good to use in that situation.
So it means, Paul, that you and I can both be glad that he has all the toys he needs.
Yes,
to do the right thing. But still, I still think it's important, because I know that there's people listening out there that are either in denial or they don't really know what's going on. It wasn't a blind leap of faith with you, but you had apparently some pretty ugly memories of the way it was the first time around.
Absolutely.
Yeah. And that's
so. What made you decide to come in, or how did you get yourself to a place where you felt safe enough so that you could kind of reinvestigate the process of being treated for that?
Well, I met you. I was talking to you and Mike, and I was looking at my legs, and then playing basketball on the side, playing golf.
Yeah.
And people going, "What's wrong with your legs?"
Yeah.
I'm like, what do you mean?
Okay, now when you say basketball, Paul's a big guy, a big tall guy, and I'm and at an age where most of the time we talk about how this is a debilitating disease that operates over decades.
Yeah.
And Paul he started off younger. He started off in his 20s. Most guys don't have the procedures that you do until they're in their 50s or 60s or even later, right?
Mm-hmm. Right. Yeah, and I think that goes to just the inheritance thing. Again, I think Paul had a very strong family history that he acquired, probably from your mother's side of the family.
Absolutely.
So you can send her a thank you note. So then, in addition to the endovenous ablation, Paul did have a huge amount of varicose veins, and he had
visible.
Right, and varicose veins in and of themselves can create symptoms. But all of that is related to the underlying venous insufficiency. So it's sort of a two-step process. Mm-hmm. We have to eliminate the underlying venous insufficiency, which we do with, the catheters that I just talked about. So that eliminates that reflux. That eliminates the blood, moving in the wrong direction. Then the second step is to get rid of those superficial veins that that are there as a result of that venous insufficiency, and we do that using the same sort of anesthesia. We numb all of those areas up, and typically when before the procedure starts, we have people stand up when we mark their leg all up with a black magic marker.
What's going on here?
Yeah. I was like, whoa. What is
and that's just our
the circles.
The circles. That's our way of showing where all those bulgy veins are. Because when people lay down, then the varicose veins flatten out, go away. You can't see them. But we numb all that area up, and then we do what's called microflebectomy. And again, that's very different from what was done in the past, because of the fact that we're not using any incisions.
Yeah. Amen.
Yeah,
We like no decisions.
It's just little needle puncture sites, and we go through those needle puncture sites, with a special instrument that we're able to, grab those bulgy veins and pull them out. So we do. So that is a form of vein stripping. We're eliminating, we're extracting those veins, but we don't like to use the term stripping because that kind of confuses people with respect to the old surgical vein stripping, which was a totally different procedure. So we call it microphlebiectomy, but it does a great job. Paul, would you like to comment on how your varicose veins have disappeared?
Absolutely, absolutely. Well, when you talk about vein stripping, if you look at my left leg here, you can see the scars, the incisions from like the toes all the way up to my inner thigh.
Yeah,
there's like incisions and scars
from before.
Before. If you look at what the doc did,
and by the way, that before was years ago, and they're still there.
Right. Oh,
and every 15 years ago.
Yeah, but here's the thing, Nate, with me is I had a couple of things that I'd had literally for 30 years. And they're gone. And when they're gone, they are like gone. There's no. It's like people wouldn't even believe I said I had a thing this big, and now it's gone. But I think that, and once again, the perspective is, were you ever concerned about it, or nervous about it, or about its appearance, or were you more worried about the symptoms?
It's the health. It's the health benefits. The appearance is one thing. I'm not that good looking of a guy to begin with, so
Oh, Paul.
My legs are like, but
no mirrors in this house. Is what
there's no mirrors in my house. But, I'm almost 6'5", 280. I'm a big guy, but.
But it's true, and it's usually
it's the health reasons.
Exactly. That's what I was more worried about because, I guess. Look at how many times we've talked about this in the past, Doc, and we've had other male patients in here where the appearance was not ever really a concern.
Sure,
it's the clogged arteries. It could lead to a heart attack. Could lead to whatever.
Well, there's mainly three reasons why we treat venous disease, and that is to, number one, first and foremost, to treat the symptoms. And I'm sure you feel like your legs feel a lot better than they did before, just with respect to the achiness, the heaviness, the fatigue. The restless leg, muscle cramping, all of those things. And that's what's so nice about doing this type of work for me now is because we have very reliable procedures to eliminate those symptoms in a very reliable way. It's very gratifying
and
for
modern.
us to. For us to be able to do it.
Modern.
But just think of your son and just being able to shoot some hoops. Where sometimes I might have said, "Hey, not today. My dad's legs are sore, man. I can't do that today."
Yeah. So the first reason that we fix this stuff is to eliminate symptoms. The next reason is because it's only going to get worse with time. Yeah. It's not, venous insufficiency is not one of those things that you can say, okay, well, I'm going to exercise more. Or I'm going to
change my diet,
or they're always going to be there.
Going to take a pill or whatever. It's not, it's not that kind of a problem. It's a mechanical problem, and so consequently, it requires a mechanical, remedy. So we treat it because it's only going to get worse. The third is that people with venous insufficiency, especially people like yourself who have very extensive varicose veins, are at a higher risk for developing things like SVT, superficial venous thrombosis, or commonly referred to as phlebitis, and then as a result of that, also developing DVT, deep venous thrombosis.
Now it's getting scary.
Yeah, which we hear about all the time. And, DVT is something that people die from. So, those are the reasons. So, there's a whole host of health reasons why we fix this. And it's, that's one of the hurdles that we have to get over often because so many people feel that even when you have, huge varicose veins, a lot of swelling and, skin problems, et cetera, they still, think it's just a cosmetic issue and, doesn't need to be addressed or I shouldn't want it to be addressed. I can't tell you how many people come in with problems like Paul or even worse. And the first question is, gee, doctor, do you think I really need to be here? Am I just being vain?
Yeah, exactly. Yeah,
and it's
That's
like,
what I said.
oh no, no, you need to be here for sure.
Yeah, and by the way, gang, just as a reference, I should have let you know that Dr. Julev is the medical director of the Vein Clinics of Hawaii on the Big Island, on Kauai, Maui, and here on Oahu. And you can learn a ton of stuff, including studies like what we're talking with Paul here about, seeing some of the conditions which you won't believe. When you go take a look at the website, a lot of work is being done there. It's veinclinicsofhawaii.com, veinclinicsofhawaii.com. It's really great that I think the most gratifying thing for me is all the patients that have said, and myself and now Paul, is that you want to find out where in the disease process are you, okay? Number one. And number two, okay, now what's the fix? There's no pills, right, yet. There might be someday. But what are you going to do to make it so that I can shoot some hoops,
Play some
go
golf.
on a long hawk, and not worry about, I can't do that today because I'm afraid my legs are going to hurt.
Yeah. Well, and in addition, I mean, we hear this all the time, too, and that is that, the people come in and say, gee, 2 or 3 years ago, I used to be, going to the gym all the time, being able to run and take walks and go on vacation, that kind of stuff. And, the symptoms are so bad that they eliminate those things from their life. So, from a health issue, not only are we, treating, the venous health of the patient, but, secondarily helping them stay healthy otherwise. So there's a lot of repercussions, definitely.
Okay, well, I want to know about Paul, though. I mean, things that you've added back into the list, things that you are doing again, and going through the pain and the appearance is one thing, but the benefits is after you've had the surgery.
Absolutely.
Now what am I happier doing, or what can I do longer?
Walking the dog,
Yeah.
surfing with my son, golfing more,
Yeah.
Mm-hmm. Yeah.
basketball.
All those things.
Absolutely.
That add to your general health,
I'm tan now.
and quality of life. You've got
I'm very tan
you've got
now.
a very nice tan,
I'm
Paul.
outdoors a lot more often.
Yeah, but
I have nice looking legs again.
Yeah,
Oh, my.
and by the way, as a big tall basketball player, shooting some hoops, you don't exactly wear long pants and long sleeve shirts and boots when you're playing basketball. So now it must be obviously appearance is one thing, but it's not the game changer. It really is. I mean, would you have done it if it was just for appearance?
No, it was the pain. It was
exactly.
the swelling, the throbbing. It just hurts. The cramping.
Okay, one thing we haven't asked about yet, and that is during the time, even before the early 2000s, when you had the procedures, the invasive procedures done, were you a person that did, on a regular basis, did you elevate your legs, and did you find some comfort doing that?
Absolutely.
Yeah.
Yeah, that's one of the questions that we ask all the time.
I still do. I like it.
Elevate the legs, the stockings, the compression stockings.
Right. Which, we use that information sometimes to decide, whether we should do procedures on somebody. And the process of,
Motrin.
having, medication to treat the discomfort. But, people that come in and they say, gee, I've got, heavy, fatigued legs. Yeah. It gets worse over the course of the day. And by the end of the day, I can't wait to get home and elevate my legs because it makes them feel so much better. Yep. I mean, that's almost what we call pathognomonic. That's like the gold stamp. That's like a stamp of, this patient has venous disease. We can feel pretty safe that fixing that is going to, correct their symptoms. But, you mentioned something before, and that is follow-up.
Yeah.
So our job now,
every 6 months, give me that ultrasound.
Exactly.
I want to see what's going on in there.
Yeah, our job now for Paul is to, keep his legs as healthy as they are right now. Now, is the situation such that, gee, we fixed everything and it's always going to be perfect? He's never going to, develop anything more, et cetera. Well, unfortunately, no. Because he has that strong genetic, predisposition to develop vein problems. We haven't changed that. Yeah. We haven't corrected your genome. So, we just took care of whatever problems were present right now. So, so then we put him into a follow-up program. And we give them advice on how to minimize the risk of developing new things like staying active, wearing compression stockings, etc. But the main thing is for us to do periodic ultrasound. I mean, that's the way that we evaluate this problem, and that's the way that we follow it. We do surveillance with it. Typically what we do is after someone has gone through procedures, we do an immediate ultrasound. Right. You had those already, just to make sure that everything looks good.
6 months.
Yeah, and then now at this point it'll be 6 months down the line that we do our first surveillance, and then if that looks okay, then yearly thereafter. Now, might you have problems at some point in the future? Yeah, you may very well, but hopefully with good surveillance and good follow-up, we'll be able to catch things early, do things in a very minimal sort of fashion, and just to keep your legs healthy over the rest of your life, because you're a relatively young guy. Right. And
I got something else, and we haven't talked about this yet, Paul, and that is that I do know that because everybody wants to either self-medicate or do something. That the other danger is, and I don't know if you ever got to that point before in the early 2000s where you would say just on a regular basis, because I did. I took way too much aspirin and ibuprofen and all of that stuff.
You used to mix them.
Yeah.
The Tylenol.
And that being said, there are some horrific things that we've learned now that people can get this opioid independent. It's an epidemic of its own. Mm-hmm. And I would think that if it works, you keep doing it, but you didn't have that. It didn't sound like that. But I took a ton of stuff before I went and got some help.
Yeah, that's why I did the vein stripping to begin with in 2005 at the Queen's Hospital.
Mm-hmm.
Was because of that, because
of
the pain.
Yeah.
And which is another reason why I waited 15 years to go see the doc over here, because I was thinking vein stripping. Oh my gosh, archaic! They're going to cut my leg open, and we got to work for a month. I can't walk.
What were you doing for the pain back then in your mid-20s?
Whiskey and aspirin.
Yeah,
that's a good combination.
Actually, and that's honest. And the thing is, thank goodness.
Yeah.
For me, those things weren't available when I really needed them, because I would have been. If you're an alpha type and you take, if you have a bad headache, you take one. If you have a worse headache, you take three. But if you and what about times that you may have said, well, I better take something before I go do something because I know it's going to hurt later.
Oh, yeah.
And now you think of all of your stomach lining that's pretty happy that you're not taking these things.
Yeah, well, and you're right. You mentioned opiate, overuse and abuse, and that can happen for sure. When people have chronic pain, and especially in venous patients who have a little more advanced processes going on, if they have skin breakdown, if they have chronic ulceration, they are definitely at risk for developing a dependence on some sort of narcotic type pain medication use. So we try to avoid that. We prescribe hardly any of those kind of medications because we feel like we can get people through these procedures using just the anti-inflammatories. But even using just anti-inflammatories chronically, over a long period of time, there are health issues with that. You mentioned the stomach. I mean, some people are very susceptible to gastritis and inflammatory problems inside the stomach and the GI tract. And as well as things like kidney function problems for people if they take too much over a long period of time. And even Tylenol, that kind of stuff also has, negative repercussions if you use too much and over too long of a period of time.
Yeah, and I think that's what I found interesting, because I remember in the very beginning when Paul first went to you, we talked about it a little bit, and I thought to myself, this is going to be a good example, because here's a guy that probably was just putting up with it for way too long, and so every time we do the program, Paul, every time there's somebody that finally says, "God, that's me,"
it's time,
and they make a decision to do that. That's why doing these little patient chats is so much more fun than. Excuse me, don't get me wrong, Doc. I love when we go through all of these words that I can't pronounce.
Don't wait, go now.
Yeah, exactly. And
it's covered by insurance.
And that's the other thing. So maybe you can explain what happens is when you go through the initial consultation, long before anything is planned, there is a procedure that you go through so that the insurance companies will provide coverage for somebody that needs it.
Yeah. Well, we do have to be concerned about a documentation for sure. But we also just want to have all of their health history and symptoms and all those things documented just for our use too.
Okay, but wait a minute. In Paul's case, in that he'd had this very invasive stuff done earlier, wasn't it easy then to say to the insurance company, well, what he had back then is now happening again. We need to do this.
Yeah. I think that for the most part, people's insurance policies cover, by and large, almost everything that we do. The only thing that they don't cover are purely cosmetic, procedures, and basically that's just cosmetic
spider veins,
sclerotherapy for spider veins. But now, do they have their own set of rules that we have to follow? Oh yeah.
We've got those rules.
We've got to follow insurance companies' rules. But if we follow the rules, and if we give them the appropriate documentation of us doing those types of things, then by and large, all of this stuff is covered by insurance. Now, there's always going to be a little bit of out of pocket for most people. Sure. Depending on how their policy is actually written.
It was a payment that I was glad to make, though, Paul. I don't know about you, but hey, listen, to go through so much discomfort and so much pain and so much, some people call it tingling, some people call it, hot, some people call it sore. I mean, but it's all pain.
Yeah,
it was numb. On some days it would get numb.
Yeah.
So, with respect to the insurance thing, that's another one of the hurdles that we kind of have to, get over, because so many people feel that none of it is covered by insurance. And they're surprised to hear that it is, or one of the first questions that they have is, "Hey, is my insurance going to cover this?" But it is again, 95% of the stuff that we do is considered medically necessary, and thereby your insurance will cover it.
But what about guys like Paul and me? That once you found out there was something wrong, you want to get at it. All right, not to fix it, fix it.
Right.
But now there's this waiting period.
Yeah.
That sometimes, and I guess you can explain it, but is it because if somebody is, say, you can't have some surgeries when you have some, some other modality, something else that's going on. How long of a period of time do they usually want you to do some sort of
conservative therapy?
Therapy before you actually do surgery?
Well, the Medicare and many of the insurance companies want us to treat people conservatively for 12 weeks.
Okay, that's not too bad.
That's not too bad. Yeah. Now, HMSA, which many of our patients have, they ask for us to treat them 8 weeks.
Okay.
And
and you keep records of that, how it started.
Right.
Okay.
So that's what we have to document. We have to document. The patient came in on this date, and we've been treating them in this way, and we need to document all that. And then we get them to the point where we can then get their procedures approved by insurance. But it usually is not a problem, and people get through the process pretty easily.
Well, it's to the point where now my GPS has vein clinics, plugged in. Because I'm just guessing, Paula, you're the same as me, that now if you saw something, you know pretty well.
Absolutely.
You know what? This is that rascal coming back. I'm going to go get this fixed now.
Yeah. Well, in the same for symptoms, too.
Yeah.
Once people come in, they may not know that their muscle cramping or their restless leg has anything to do with, vein problems. But now you do after you've gone through it, and you can say, gee, and we hear that, 2 years down the line, 3 years down the line, gee, I'm starting to develop more, crampiness at night, and we do an ultrasound and figure out what the problem is and take care of it.
Well, I'm glad that we were able, Paul, to get you to come in and share your story with us, only because I think that there's any number of exact people out there today that it's either they are exactly what you are, or their spouse or their loved one says, hey, you know what, I'll listen to this guy on the radio, man. You got to go and see this
Absolutely.
Dr. Julep. You got to go get this taken care of.
Yeah,
Yeah.
it's not painful. It's non-invasive.
Yeah.
There's no downtime. It's amazing.
Get her done. Thanks, Paul, very much for joining us. And Doc, we'll see you next time.
You bet.
Yeah, and if you're out there wondering what's going on, you want to go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. Remember this, a little consultation. First of all, it's a real good idea, particularly if now after this pandemic and all the things we've been going through, if you're planning on doing a lot of travel and everything else, you'd be really good to make sure that you are in that kind of shape that you can travel. So tell somebody that you listen to the program, and hope and want to thank you for spending some time with us. We'll see you again next time on Vein Clinics of Hawaii on the Air.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.